Well, thank you so much for tuning in. My name is Kevin McAvey. I'm a health data strategist, and it's my absolute pleasure and privilege to get to work with the Robert Wood Johnson Foundation and Academy Health and get to support and cast a spotlight on so many of the health data for action grants and programs being sponsored by Robert Wood Johnson Foundation and Academy Health. Data-backed evidence is a powerful tool for helping researchers, community advocates, policymakers, and others uncover health challenges, better target resources, and measure progress toward ensuring that everyone has a fair and just opportunity to achieve their best health. Yet for too long, many researchers across our country have had limited access to rich data, a cornerstone of producing timely and objective research. Health Data for Action, or HD4A, provided novel support, democratize data by facilitating the pairing of owners of highly valued data assets with researchers to generate actionable insights to create fairer, more effective health solutions that work for everyone. Again, I'm Kevin McAvey. I'm really happy to be and privileged to be moderating a number of these conversations. And today we have Dr. Carrie McAdam-Marx of the University of Nebraska Medical Center. Dr. McAdam-Marx HD4A study demonstrated the potential of data-driven policymaking. Plain and simple. Her study generated evidence to support a $35 cap on insulin out-of-pocket costs that was then adopted by Medicare and the private industry. We're going to talk to her a little bit about that. And Josh Caplan, government affairs at AcademyHealth, who plays a linchpin role in helping researchers actually take the data and information they derive from that data and get it into the hands in a way that for policymakers and others to actually make sense of it and use it to make change in a policy environment. So I'm so happy to have you guys here. Thank you for taking the time to chat with us and share a little bit about your research with the broader world out there. So thank you for joining us, Carrie and Josh.
Thanks for having us.
Of course. So actually, Dr. McAdam-Marx, is it okay if I call you Carrie?
Please do.
Okay. So Carrie, so you've been on like a journey, like just academically for a while, and I would love if you kind of unpacked your journey and how you arrived in the position that you're at, and to get into research like this.
Yeah. So I'm a pharmacist by training. I went to pharmacy school quite a while ago. I had the opportunity and the privilege of working both in hospital settings and PBM world, the pharmaceutical industry world, before going back and getting a PhD in health policy. Just really an interest in being able to make a difference in how medications are used and accessed and priced in the United States. And so that has led me into an academic role. So I'm currently on faculty, as you said, at the University of Nebraska Medical Center in Omaha. From a research perspective, I'm an outcomes researcher. I focus on policy relevant research related to diabetes and access to medications and pharmacy services that can help them manage their disease and promote better outcomes.
Yeah. And what's so impressive about your work, and I was looking through it in advance of our conversation today, is how it's so grounded in real world issues and really thinking about solutions. I mean, is that a particular path when you were kind of thinking about like what type of role you wanted to have in academia? How'd you kind of wind up in that space?
Yeah, I mean, you're right. From day one, when I started my first research related role as a PhD student, was looking at real world data. And really recognizing that clinical trials are important. They tell us whether drugs work, for example, very controlled, great, and we can generally trust the results really well. But they are so controlled, we don't know that patients are going to get the same results in their real world setting when they don't take their medications as prescribed, or maybe they aren't going in every 3 months for a follow-up and lab values and to check on how they're doing. So I worked with a research group at the time and just thought recognized how important it was to have that information so that payers and providers and even patients could begin to understand what they can expect when they're taking the drugs in the real world as opposed to what was observed in the clinical trial setting. We always hope that we can replicate it as close as possible, but I think that real world element, it doesn't replace clinical trials, but it gives us additional information in which decision makers can use when they're making clinical or policy decisions.
You mean patients don't always follow prescribed behaviors?
Well, And pharmacists can be the worst. Yes, not always. For a variety of reasons, patients don't take their medications as prescribed, and cost is one of them.
Yeah. Well, it's so nice to have you here. I'm really looking forward to digging into some of your work. And Josh, I mean, on the translation end, to make it, can you talk a little bit about your role at Academy Health and why that translation is so important?
Absolutely. Before coming to Academy Health, I spent 7 years on Capitol Hill as a staffer, split between being a senior aide on the Senate Budget Committee and a legislative director for a House Appropriations chairwoman. One of the things that would drive me crazy when I was a staffer was not having access to the evidence that I knew had to have been out there. So coming to Academy Health, um, my priority has been we all like to talk about the idea of evidence-based policymaking, but if you're not getting that evidence to policymakers in an accessible, timely, digestible, and reliable way, evidence-based policymaking is just a bumper sticker and frankly not a terribly good one. So what we've been doing at Academy Health has been working with researchers so they see policymakers as a key dissemination audience for the work they do, work out with them on how to communicate effectively, connecting them to policymakers at the federal and state level, and really getting that evidence into their hands so that they can make the best decisions possible.
Yeah, and I want to come when we kind of turn the corner of our conversation today. I'd love to come back to like tactics that you found to be really successful in translating this information into an audience to an audience that's really receptive, particularly in today's environment. But Carrie, I really just am such an admirer of your work, and I would love to talk a little bit about it. And I always start off these conversations by really thinking about what is the issue and why should people care about it. Can you talk to me about like a little bit about like the number of folks who require insulin, and what was the issue that you were seeing that kind of drove this study and its interest?
Oh, sure. So, I mean, I think most people are aware that diabetes is somewhat of an epidemic in the US and worldwide. Right now, approximately about 1 in 9 people in the US have been diagnosed with diabetes, which is about 30 million.
One in
Um,
nine people.
1 in 9.
Yeah.
And, it can be a really serious disease when it's not managed very well, that people have, they're much higher risk for things like heart attack and stroke, for kidney failure and blindness. And so it really is in everybody's best interest if patients with diabetes are diagnosed early and treated appropriately and aggressively, with the patient being a partner in this treatment so that they can really maintain their blood sugars and manage their risk factors. Um, but one of the key elements in doing that, or one of the cool key tools in our armatorium um, of care, is insulin. And so of that 30 million with the type 2 diabetes, there's about 5% that have type 1 diabetes. And I think a lot of people may know this as juvenile diabetes. It's
Mm-hmm.
diagnosed in younger individuals, and they need insulin to live. Their body has quit making insulin. And so all of those patients are on insulin. But the more common type is type 2 diabetes, or sometimes referred to as adult onset diabetes. This is a case where patients tend to still be making insulin. Their body just doesn't use it very well. They can be on oral meds or other injectables to help them manage their disease, but insulin is super effective. And so there's a portion of those patients that will go on insulin to really help them achieve their diabetes treatment goals. And so right now we have about 25% of those patients are on insulin. For about 8 million people across the US are taking insulin on a daily basis to manage their diabetes.
That's a huge segment of our population. And I want to kind of talk about that segment of the population and like the costs and barriers to access that many of these folks might face for insulin. But I just want to kind of linger on this 1 in 9 number, which I think is just stunning to me. And Josh, I don't know if you've seen anything even on the Hill when you kind of talk about diabetes and its prevalence. Is that a surprising number? I mean, it's surprising. It's surprising to me. And as we think about like making America healthier to get to, again, like, I mean, I think that's a really kind of stunning statistic.
Yeah, so I mean, I think that a lot of congressional offices recognize that diabetes is a very serious chronic condition that is not just harming patients, but also burdening the healthcare system. And
Mm-hmm.
finding more effective ways to be able to deliver care helps everybody. The challenge, though, is getting the evidence to them that they can act on. It's one thing to tell them about the problem, but it's another thing to give them a solution.
Yeah.
And if it's an evidence-based solution that they can really digest and understand how the mechanisms work, it has a much higher chance of finding its way into a bill, into a law, into a regulation, and eventually into the doctor's office.
Yeah. So I mean, we have the issue of like the prevalence of diabetes, and then like Carrie, from your research, which really carefully outlines a little bit more of the problem, not like that a number of these folks, as you were just discussing, require insulin on a regular basis. Like, can you talk a little bit about the barriers, particularly around costs, that these folks might face?
Yeah, there's, as mentioned, there's a number of barriers as to why people don't take their medications as prescribed. It may not be very convenient for them, and with people on insulin, they've got to take injections, so that's a barrier when you're at work or at school. It may have side effects, so sometimes insulin causes low blood sugar, and that can be daunting for people and scary. But cost is also a major issue with insulin, and it has become so much more expensive over the last couple of decades that it has gone from being just a cost to being a substantial cost for people with diabetes. And so if we want to keep people on their medications and keep them as healthy as possible, keep their risk factors as low as possible, we have to address all of these factors. But I think from a cost perspective really lends itself well to policy.
Yeah.
And what we can do in making medications available and affordable to the patients that need them, including patients using insulin.
Yeah. So, like barring any kind of a policy intervention, do you have a sense of what the costs of insulin for an average person might be, just so we can give folks like a gauge for just how much of a barrier it could be?
Yeah, in some degrees, this is how long's a piece of string, because insulin is used from very small doses today to very large doses a day. It just depends on what the patient needs. But I would say a month's supply of insulin for a patient that's on an innovative product is probably over $2,000 in cost. And then their out of pocket is a portion of that. It's not all of it if they have insurance. So,
but that's, I mean, when we talk about like healthcare costs, and also the cost just required to live a high quality life and a productive life, I mean, those can be significant costs for most Americans, right? And these are not optional treatments, right? I mean, like, these are insulin doses are needed on a regular basis in order to kind of maintain that daily standard of living. Is that fair?
Yeah.
So when we think about for me, this always comes back to like this balance between a market driven system and some of the effects that it might have on like what we feel are like social goods, or we really want to make sure that individuals have access to treatments that they need. And so when we were talking about this $35 like price cap, like can you kind of bring me from like where your research played a role in kind of understanding the price, how big a barrier price was to constituents, and then getting to this $35 number?
When we were designing our study, there was actually policy activity ongoing, it kind of in its infancy. So, for example, some of the PBMs had begun to set price caps, and there was a pilot with Medicare Advantage by the CMS that was piloting a $35 a day per month supply cap for insulin. At the same time, the states were beginning to implement out-of-pocket caps for insulin for the commercial insurance plans that they had jurisdiction over, and they were ranging anywhere from kind of roughly to $20 to $50, or some more than that. And then we also saw at the time, it didn't come to fruition, but there was a piece of legislation proposed by a U.S. representative that would have capped insulin at $20 a month for all commercial, Medicare, Medicaid, and uninsured. It was a very broad-reaching policy that, had it been passed and implemented, would have really had significant implications on the cost of diabetes to people. So when we designed our research, we didn't necessarily look to find a specific dollar amount. What we looked is at the cost of insulin that patients are paying out of pocket per month around these categories of policy activity. So we had one category that looked at what if their copayment amount or the amount they were paying for insulin per month was less than $20. What if it was in the $20 to $35 range? What if it was 35 to 50? And then what if it was at that really high end of over $50 a month per month supply of insulin?
Yeah.
And so then we looked to see where did we start seeing points of which people were sensitive within these buckets rather than identifying a specific cut point. And we did this because there were policy activities already in place. We weren't trying to come up with that dollar amount ourselves as much as assess what was already being considered and implemented.
And where did you find that price sensitivity? For which population groups?
Yeah, well, it differed, and it's not particularly surprising. So one thing we did is we divided our groups up so that we looked at commercial separate from Medicare Advantage, so age differences and differences in insurance coverage and stuff. We also looked at our type 1 patients, the type 1 patients separate from the type 2 patients, because we know that they're likely to be different sensitivities because type 1 needs it, type 2 it's part of what they're already taken. And we thought we were afraid we'd miss some of the other nuances if we rolled all of these groups up together and looked at them together. So with that in mind, what we found was that patients with type 1 diabetes were surprisingly not as price sensitive, but we did start seeing that patients start being less adherent, so maybe not using as much insulin as prescribed or stopping, slowing down on their insulin when it hit about $50 or more a month per month supply of insulin. So kind of at our highest category. Not surprising. They don't have other options other than rationing, right? And so when we looked at the type 2 patients, we saw that difference in adherence emerge at that $35 mark, where Medicare, where some of the PBMs and some of the states were really starting to circle around and start to build their policies around, which I think really added additional emphasis that was probably the right amount, because to kind of that balance out, what's the cost of the plan? How do we keep our premiums affordable? What's the appropriate cost share for patients where they'll still take the medication that they need without that becoming a barrier that they then have to start making some life decisions about whether they're going to take insulin or not.
Yeah.
So everything, we very much developed it around the policies that were, and the decisions that people were trying to make. We wanted them to help them make those decisions based on what they were already thinking and seeing.
Yeah, and it's so clear even just by how your methodology and how your research was focused and how you're presenting it, that you were thinking about and you were acknowledging signals from the market. You were kind of like building this model within an environment where different plans have already kind of put out caps, and I assume that informed your cohorts for testing price sensitivity.
Yeah, it definitely did.
Yeah.
Again, if we wanted to be actionable, we wanted to think about what are the decisions people are trying to make.
Yeah.
So we tried to design it around that.
And I want to get to the policy implications here, because Josh, I know you're kind of chomping at the bit. Well, I want if we could get nerdy for a second. Let's can we talk about the data you used?
Yeah. So, did you want Josh or me to answer that?
Yeah, I would love, maybe Carrie, if you could start off, and then Josh, I'd love any thoughts that you have on the data too.
Okay. All right. So to answer a research question and to get the best evidence that we could out of it, we knew there were certain elements that we needed. So we needed information on how much insulin patients were using and how much it cost. And we can get that from pharmacy claims data because the patients are purchasing their prescriptions, pharmacies are billing it to the insurance companies, they're paying it. Very rich, very accurate data on insulin use, as long as it's going through being claimed by the patient and they're using their insurance benefit for it. So we needed that. That was critical. We wanted information on diagnoses and other comorbidities and risk factors that the patient had. So that requires some medical data to get the diagnosis codes. So those are kind of a classic claims database. But we wanted more because there's more than just that to help us understand the question and some of the other factors that play into whether patients decide to be adherent or whether cost is going to drive their decision to stay on their medication or take it as prescribed. So one of the things we wanted was to know how well are they managing their diabetes? So are poorly controlled patients more sensitive than well-controlled patients, or maybe it's the other way around? So we wanted laboratory data that would give us a measure of the patient's diabetes control over time. And so we knew that was going to be really important and a real limitation if we couldn't account for that. And the final factor, which is kind of, to me, super obvious, is we needed to know more about the patients. You know, what were their socioeconomic status? What was their life like? So we wanted some information to guide us and provide some insight on what's household income, what's the educational level, and things also like race and ethnicity. And so these are all, you got your claims, you got your demographics, you got your lab. These are three separate sources of data.
Yeah.
So one of the data partners in the Health Data for Action program was Optum Labs Data Warehouse, and they had all of those. So it's like to think about our research question and to look to see that data was an option. It was really a no-brainer. It's like, that's the one for us. That's the data set that will help us answer this question.
Yeah, that's amazing. I mean, I live and breathe claims and encounter data every day, and I'm just like, where'd you get the demographics from?
Yeah, that was a huge selling point.
Yeah,
it really was.
It sounds like Optum Lab. Not that this is not sponsored by Optum Labs, but like they were able to kind of bring these different data sources together. And I want to talk a little bit about like what you actually what the request process looked like and what you actually wound up getting for analysis. But Josh, I mean, even through this, I'm hearing just such valuable like linkages between data assets and allowing it to get the information you need that can be actionable.
Yeah, and there's a lot of things I've loved about Carrie's work on insulin and the ability to make it so actionable. She was able to stratify, we were able to understand different outcomes in different populations, and it was something that could be easily understood and digested. It was the ability for like a policymaker to almost twist a dial. Well, what happens at $20? Well, what about at 35? What about at 50? What if we go above that? And allows them to just see where the best outcomes are based on the evidence and the data. It was incredible to be able to work with that.
It is pretty cool. And I actually want to kind of come back to thinking about like our policymaker audience. Are we thinking for projects like these at the state level, the federal level? What advice would you have for other researchers when they're thinking about designing their own methodology and outputs? But sorry, Josh.
Oh yeah, I would love to be talking about policymaker audiences. Yeah. One of the things that I always tell researchers is identify who has a hand on a lever of power. Like who is doing any sort of policy work on insulin pricing? Is that happening at the state level? Is it happening at the federal level? Is it something that CMS is doing? Is it something that Congress needs to be doing? Identify who your audience is and then target that audience. You want to make sure that you're really impactful with the people that you're talking to and making sure that they're able to actually follow the call to action that you have.
Yeah, and even like as Carrie's been leading us through, like understand like the story. Like these are folks who need this for this reason, and this is the barrier they're facing, and this is how we could potentially address it. And I think Carrie, you were leading into that earlier. But Optum, it sounds like they brought these three data resources together. Is that something? I mean, it sounds like you had a prior conversation to talk about what you needed, and like how did it ultimately come to you for work analysis?
Yeah, I mean, so it was like as we were preparing our grant submission for the Health Data for Action program, we had the opportunity to hear from the different data partners and hear what they had to offer. We also had the opportunity to pose questions to the Optum Labs data warehouse team to say, we have this question, would your data support this? So we were able to really tap into them to better understand their data to make sure that it actually would support what we wanted to do. And then through being a grantee of the program, then AcademyHealth just basically paved the way for us to have access to the data and working with Optum Labs to have that data available to answer our research questions.
That's really helpful. And so, Josh, now we have this data and information thanks to Carrie's study. What advice would you have for others when taking that information and actually kind of bringing it to a policymaker audience, making sure that it resonates with them?
So the first thing that I always like to talk about is when I was a congressional staffer, I was swamped with meetings. And yet I would always hear researchers talk to me about, well, I don't know if I should be talking to Congress or talking to policymakers about the work that I'm doing. And I'd always ask them, if experts weren't talking to me in those meetings, who were? And what are the implications on the policy that we are making because of that? And it's so critical to get researchers talking about the work that they are doing and how actionable it is to these policymaking audiences. The first thing I always say is let's make something that's digestible. Let's get a nice one-pager. something that has clear points, a nice graphic, something that somebody can look at for about 20 seconds and get a good idea of the research that you've done and what the implications of it are. I then talk to them about how we set up meetings, how we identify which policymakers on the Hill, for example, are most likely to be interested in what you have to talk about. Maybe it's your representative who represents you. Maybe it's somebody on one of the health committees. Maybe it's a member that has put out a number of pieces of legislation on insulin or diabetes care. These are all things that you can find on congress.gov. It's a very easy, accessible way to figure out who's really already talking about what you're interested in.
And they can call you.
And,
right?
and then they call me. Yeah. But like one of the things that, and obviously at Academy Health, we love bringing researchers to policymakers. It's our driving focus. And we are not gatekeepers on that. One of the things I think is so important is just taking the black box off of policymaking and empowering researchers to be able to do this work. It's such a critical part of adding the impact, because that's why you're doing this research in the first place, is you want to influence the world around you through better evidence, and this is a pathway to do it.
So I want, that's, it's really sage advice. And Carrie, we spoke about kind of the problem that you were trying to investigate, the methodology and the data you used to investigate it. Josh just kind of outlined a roadmap for how he would recommend many researchers then take that data and information and bring it into the policy world. So like, as we're kind of rounding the curve here on our conversation today, I'd love to hear about like what happened. So talk to me about, like Josh mentioned, the one pager. What was that like one pager of results, and then how was it received in the environment?
Yeah, it was a wonderful experience, and I'm going to lie. I would lie if I told you it wasn't intimidating for me. The thought of talking to people on the Hill and politicians, and I'm like, no, I'm good at talking to researchers, but I knew that we would be selling our research short, and we would just be, like I said, just kind of leaving it in limbo if we couldn't get it out in front of the policymakers. And so Academy Health and Josh and the team were wonderful. It started a lot just right from the early stages of the program and the research funding, as they had programs for all of their grantees, to really begin to think about how do we communicate, how do we find the right messages, and how do we communicate our policy findings, our policy relevant findings, to the right people and to the decision makers. And so beginning to think about, identifying, like I said, as Josh said, who has their hands on the lever, who is that person, what do they need to hear, what information do they need to know, and what about our research is going to help them answer that question. So really kind of getting things set up and getting us prepared for that. And then once we actually had data and results that we could start taking out, then the Academy Health team was wonderful at working with me and putting together that one pager and really having that great eye of helping us get down to what's important. You have a 10-page paper here with lots of facts and data, but what are the few things that are really, really relevant and going to make a difference? What does that person that's making the decisions need to know to grab their interest, to answer any questions that they may have, and to bring home that message. And so it was a great experience.
Yeah.
Good skill, super good skill to have in terms of being able to do that, but not one that comes natural to us as researchers.
Yeah. So like insulin out-of-pocket costs, what was the upshot? What did people grab onto of that one pager? Like, what was the key data point that you found?
I think really that it just really helped to drive home the point that what patients are paying out of cost really matters. Mm-hmm. And if we want to drive good outcomes, we have to think about the cost of drugs. It's not to say we ignore all of the other barriers, it's the only other one, but that if we don't address costs, we're never going to be as successful as we can be in terms of getting patients on insulin and keeping them on insulin. In some regards, I feel like we were, I don't know that we were preaching to the choir, but I think people kind of got that. But I think having more specifics and facts and some numbers, like $35 matters for a type 2 population, $50 matters for a type 1 diabetes, but in every case, cost matters, really, I think was probably one of the strongest take-home points for the people that we were talking to. And Josh, I would love to hear if you felt the same way from our meetings.
Absolutely. And like one of the things that I always like to emphasize is that these staffers, these offices don't have to take your meeting. The fact that they are taking it is because they're interested in hearing from you. And I would say that the overwhelming, hugely vast majority of meetings I have with congressional offices are very positive. Mm-hmm. They want to hear what I have to say, what our researchers have to say, or otherwise they just won't take the meeting. So it's a far friendlier audience than you think it's going to be.
Well, I mean, you heard on CNN and you're like, that's who I'm going to meet with. I mean, like, so, but in reality, it's a little bit of a different environment and reception, right?
Yeah, I mean, one, you probably actually aren't meeting that member who's on the TV. And this is probably my bias coming out as a former staffer. I think the staff are the one you want to talk to. They're the ones who are really thinking through the legislation. They're thinking through the talking points, the press releases, the speeches. They're deciding how to vote on bills or how to amend them. The member is obviously very important, but I think the staff is the ones that you really want to be hitting with this research, and they can then bring it to the member or add on additional conversations and relationship building there. But it's a far friendlier audience. There's something Carrie had mentioned that I want to put a little exclamation point by. The idea that researchers aren't trained how to speak to these audiences. And I agree. I think that the most important aspect for a researcher is really your methodology. Like, how did you get to your answer? And if that is rigorous and accurate, then your answer is rigorous and accurate. But your policymakers don't really care about that. None of them are going to look at your logit models. None of them are cracking open your data. None of them are doing that. I know it's they're not even really looking at how many little asterisks you have by each number. What they're looking for, though, is the conclusions, the story. Like, I am a researcher. I found this. And here's why I was doing that type of work. And here's the story behind it. And if you're interested in diving into a methodology conversation, I'd love to have it. But that's not what they're looking for. They're looking for like that, they're looking for those conclusions, those big, like, what are you trying to tell me? We have 15 minutes to have this conversation. What should I know? And the modeling isn't what you necessarily need to know. It's the conclusions.
So I have two final questions for you guys. And these are lightning round questions. One is about like lessons learned from translating data into information. Like, how did you find the right data source? What made this one particularly useful? And lessons for other researchers. And the second, like, how do you take that information and get it to actually kind of create change? Which I would like to, like, I really do think that this environment, this study helped to create real policy change out there. So to the first one, like, what should researchers be thinking about when they're trying to decide like which data resources and assets to engage to kind of move to get the information they need? Carrie, you want to go first on that one?
Sure. And I think this is just a generic question that could probably apply to about any research, is to really understand your research question and how you can answer that question. How can you operationalize that question into something that you can answer, and then look for the data. I think sometimes it's real easy to start with the data and try to figure out what we can answer with it. But in most regards, that's kind of backwards. You should try to figure out what you need first and then go find the data that meets it. And that's where, how we figured out that Auckland Labs Data Warehouse was the right fit. We knew what we needed to answer our question.
That's terrific. Josh?
Yeah. And along that line, so I'm not the person to be asking about which data sets to be using. But thinking about that research design and how to maximize your policy impact, a suggestion that I often have is if you're really at that early stage of thinking about like, what kind of question am I trying to answer? And like, really, what's the problem? I recommend talking to policymakers. Like, set up those meetings early on and be like, hey, I am about to undertake this research project on this question. What questions do you have? What evidence are you looking for to be able to act on? And am I able to answer that in this project? And that's building a relationship. And they have buy-in because they know that they are part of your team. And then as you are doing your research, as you get preliminary information, you go back and you say, hey, here's what we're finding so far. What are you thinking about that? Is this affecting how you guys are thinking? Have those sorts of conversations. As research gets finalized, going back. As it gets published, going back. And building this relationship so that they know you're doing this work. You know what kind of questions they're looking for, and you're able to maximize the impact and influence of what you're working on.
And I think that even goes to start answering the second question too, because then you're lending yourself to success by actually engaging that audience early and really thinking about what information at the end of the day they need to do what they do. But anything else you'd add?
Yeah, and I think that there's always this like concern in the research community of if I'm only able to talk about this very narrow area, and that's all I can possibly talk about.
Mm-hmm.
And that's not true. Researchers are incredibly smart. They're very well read. They're far more available to be answering questions and being able to influence conversations than just the narrowest interpretation of their research, right?
Yeah.
Like you can talk about other questions and you can answer other questions, and you can also kind of figure out where you want your research to be going in the next few years. Like what seems to be a coming hot topic.
And Carrie, does that resonate with you? You mentioned when going to the Hill the first time or kind of talking to some of these policymakers and their staff, it's a little bit of a nerve-wracking activity. But like, what lessons would you have to share with other researchers who are thinking about making policy forward and put information available?
Yeah, I mean, I think I echo so much of what Josh says in terms of learning and approach, but definitely don't be afraid. Don't be afraid to try.
Yeah.
And much as researchers are also very curious and self-learning, make this part of your self-learning is figure out how to communicate to audiences beyond other researchers or other experts in the field, and then fostering those relationships. I think the Academy Health, the Health Data for Action program gave me one experience, but it would behoove me and any researcher to build on that, and for each subsequent research, continue to build a network and of policymakers and decision makers and Joshes of the world to help those introductions to say, really, I do want to do this, answer this policy related question. How can I approach it in the best way possible that brings the most utility to those decision makers?
Well said. And
it's not a one-off. So,
any closing thoughts, Josh?
Yeah, I mean, I think that, like, more largely, we're having a real crisis in this country about trust in science. And I think one of the solutions to that is transparency and bringing people in and engaging with the evidence you have. And I think policymakers are just one of those audiences that we need to be bringing this evidence to them, dispelling the myths that they might have or the misconceptions that they might have. Our belief at Academy Health is if you're using the best evidence, you're going to get the best policy. Like that's our guiding star on it. And I think you can improve trust at the same time.
Well, Carrie, thank you so much for all the work that you do, and Josh, all of the work that you do to actually kind of make a lot of this information available, and also through the Health Data for Action program, set up a model for others to hopefully follow and replicate in their own work, really kind of thinking about the research questions that they want to answer to address a public policy concern, how they approach data, how they get to that information, and how they get that information in the right hands to make it actionable. So thank you both for all that you do, and for the Health Data Action Program for not only sponsoring that work, but helping us all to get together today. Thank you so much.
Thank you for the opportunity. And thank you, Josh and Academy Health, for all that you've done to support me in my research.
It's been great research. It's easy to do.